The midwife's hands probe the laboring woman's belly. Something is wrong. The baby isn't positioned head down. She feels feet, a bottom, maybe a shoulder. This is a breech birth, and in medieval Europe, that often meant a death sentence for both mother and child. No surgical options exist. No anesthesia can ease what must happen next. The midwife has only her hands, her experience, and perhaps an hour before complications become fatal. She must turn the baby inside the womb, guide it into position, or find a way to extract it feet first without tearing the mother apart. How did medieval midwives perform these desperate manipulations, and how did anyone survive when everything went wrong? Before we uncover the brutal techniques that stood between mothers and death, if you're fascinated by how medieval women faced childbirth's most dangerous complications, subscribe now. The most harrowing part is still ahead. In a normal medieval birth, the baby emerged head first after hours of labor. The midwife waited, offered encouragement, and caught the infant when it came. But breech births, where the baby presented feet, buttocks, or shoulder first, defied this natural process. The midwife recognized a breech immediately. Labor progressed too slowly, the mother's belly felt wrong, or during examination, the midwife's fingers found the wrong body parts. Breech births were deadly for clear reasons. A baby's head was its largest part. When it came first, it dilated the birth canal, making passage easier for the smaller body that followed. But when feet or buttocks came first, the body might pass through while the head got stuck. The baby would suffocate, wedged in the birth canal with its head trapped inside. The mother would hemorrhage or suffer uterine rupture as contractions continued, forcing the stuck baby downward. Medieval medical texts described breech presentations in clinical terms. Physicians categorized different types: complete breech with feet tucked, footling breech with one or both feet leading, shoulder presentation where the baby lay sideways. Each type required different approaches, and not all could be resolved successfully. Midwives, however, learned through practice, not books. They trained by assisting experienced midwives through dozens of births, watching, helping, and eventually handling complications themselves. A skilled midwife knew what a properly positioned baby felt like and recognized immediately when something was wrong. The moment a midwife confirmed a breech, the atmosphere in the birthing chamber changed. Other women present, mothers, sisters, neighbors, who had come to support the laboring mother, understood the danger. Prayers intensified. Someone might send for a priest, not to perform last rites yet, but to be ready if needed. The midwife's assistant prepared additional linens, expecting heavy bleeding. The midwife's first action was assessment. How far had labor progressed? Was the baby still high in the womb, or already descending? Could the baby be turned, or was it too late for that? The answers determined her approach. If labor was early, before the water broke, and before the baby descended too far, the midwife might attempt external version. This meant manipulating the baby from outside, pressing and pushing on the mother's belly to rotate the baby into a head-down position. The technique required strength, precision, and luck. The midwife placed her hands on the mother's abdomen, feeling for the baby's head and buttocks. She pushed firmly, trying to tip the baby into a somersault within the womb. This was agonizing for the mother. The pressure was intense, the manipulation painful. If successful, the baby rotated into proper position, and labor could proceed normally. But external version often failed. The baby was too large, positioned too awkwardly, or surrounded by too little amniotic fluid to move freely. The uterine wall was too thick or tense. The mother's body resisted the manipulation. When external version failed, the midwife faced a terrible choice: attempt internal manipulation or let labor continue and hope for the best. Internal manipulation meant reaching inside the womb to reposition the baby manually. This was dangerous, invasive, and excruciatingly painful. The midwife's hand had to enter through the birth canal, navigate past the cervix if it was dilated enough, and grasp the baby's limbs or body to pull or push it into better position. Medical texts warned against this procedure. Physicians knew it caused tearing, hemorrhage, and infection. But midwives did it anyway, because the alternative was watching mother and baby die. The midwife anointed her hand with oil or lard to ease entry. She inserted her hand slowly, feeling for the baby's position. Once inside, she had to work by touch alone, identifying body parts and deciding how to adjust them. If she found the baby's feet, she might pull them down, attempting a footling breech delivery where the feet emerged first. This was still dangerous, but more survivable than other breech positions. The midwife pulled gently but firmly, trying to guide the baby's body through the canal without letting the head get stuck. If the baby was sideways, shoulder first, the midwife faced the worst scenario. She had to push the shoulder back and try to reposition the baby entirely. This required reaching deeper, applying more force, and risking serious internal injury to the mother. Sometimes it worked, often it didn't. Throughout these manipulations, the mother endured unimaginable pain. No anesthesia existed. Strong women held her arms and legs to keep her still. Others wiped her face, offered water, and prayed. The midwife worked as quickly as possible, knowing that prolonged manipulation increased risks of shock, hemorrhage, and infection. If the baby began to emerge feet first, the midwife shifted to managing a breech delivery. Her goal was to prevent the head from getting trapped. She supported the baby's body as it emerged, keeping it angled correctly. When the shoulders appeared, she carefully delivered one arm, then the other, maintaining the baby's position. The critical moment came when only the head remained inside. The baby's body dangled, still attached by the umbilical cord, but unable to breathe because the head was stuck. The midwife had minutes, perhaps seconds, to free the head. She reached up inside the birth canal, feeling for the baby's face and head. Using her fingers, she tried to flex the baby's head, tucking the chin toward the chest, which reduced the diameter and allowed the head to slip through. If the head was truly stuck, the midwife might use hooks, specialized tools with blunt curved ends, to grasp the baby's jaw or eye sockets and pull. This was brutal, often fatal for the baby, but it might save the mother. The tools were kept ready in the midwife's bag, used only when no other option remained. Some babies died during breech deliveries despite the midwife's best efforts. Asphyxiation was common. The cord compressed, cutting off oxygen before the head emerged. The baby turned blue, then grey, then stopped moving. The midwife continued working to deliver the dead infant because leaving it inside would kill the mother. When a baby died during a breech delivery, the midwife still had to remove the body. If it was intact, she pulled it out carefully. If it had been mutilated by hooks or torn during extraction, she removed it piece by piece, a horrific process but necessary to save the mother's life. Mothers also died during breech births. Hemorrhaging was the most common cause. The prolonged labor, the manipulation, the tearing, all contributed to massive blood loss. The midwife and her assistants tried to stop the bleeding with pressure, packing the vaginal canal with cloths or applying herbal preparations believed to staunch blood flow. Sometimes it worked, often it didn't. Uterine rupture killed quickly. If the baby was too large, stuck too firmly, or manipulated too forcefully, the uterine wall tore. Blood poured into the mother's abdominal cavity. She went into shock within minutes, became unresponsive, and died shortly after. There was no treatment for uterine rupture. The midwife could only watch helplessly. Infection killed more slowly. Days after a difficult breech delivery, the mother developed fever, pain, and foul-smelling discharge. Puerperal fever, caused by bacteria introduced during the birth or manipulation, spread through her system. Without antibiotics, most infected women died within a week. Medieval midwives understood these risks experientially. They had seen women die from breech births. They knew their interventions sometimes caused the deaths they tried to prevent. Yet they intervened anyway because doing nothing guaranteed death for both mother and child. The church played a complicated role in breech births. Midwives were required to perform emergency baptism if the baby seemed unlikely to survive. During a breech delivery, when only the baby's feet or buttocks were visible, the midwife would pour baptismal water over whatever body part was accessible and speak the baptismal words. This saved the baby's soul even if its body couldn't be saved. Some midwives carried special tools for emergency baptism, small syringes or tubes that could be inserted into the womb to pour baptismal water directly onto an unborn baby's head if death seemed imminent. This bizarre practice was endorsed by church authorities who feared unbaptized souls more than they feared medical complications. Priests sometimes attended difficult births, not to help medically, but to administer last rites if the mother was dying. Their presence added spiritual weight to an already desperate situation. Some women found comfort in religious rituals, others found them terrifying, a confirmation that death was expected. Not all breech births ended in death. Skilled midwives did save mothers and babies through successful manipulation, careful delivery, and sheer determination. These successes built reputations. A midwife known for surviving difficult births was sought after, paid more, and held in high regard. Training the next generation of midwives meant exposing them to these complications. Young women learning the trade attended breech births, watched the techniques, and eventually performed them under supervision. The knowledge passed from woman to woman, refined through generations of desperate attempts. Some midwives developed personal techniques, slight variations in how they positioned their hands, how they angled the baby, how they timed their pulls. These methods weren't written down, they were shown, practiced, and inherited. A successful midwife might train her daughter or a promising apprentice, ensuring the techniques survived. Medical authorities, mostly male physicians, viewed midwives with suspicion. They criticized midwife practices, claiming they were superstitious, unskilled, or dangerous. Yet physicians rarely attended births and certainly didn't handle breech deliveries. That work remained in midwives' hands because no one else would do it. Occasional male surgeons attempted breech deliveries, usually after the midwife had given up. These interventions often involved destructive techniques, using instruments to dismember stuck babies to extract them in pieces. The goal was saving the mother by any means necessary. These procedures were horrific but sometimes effective. Cesarean sections existed in theory, but were almost never performed on living women. The operation was reserved for dying or dead mothers, an attempt to save the baby after the mother was beyond help. Surviving a medieval cesarean was nearly impossible due to hemorrhage and infection. Breech deliveries, as dangerous as they were, offered better odds than surgery. The physical toll on midwives was significant. The work was exhausting, emotionally draining, and sometimes traumatic. A midwife might work for 20 hours straight during a difficult breech birth, fighting to save lives, only to watch both mother and baby die despite her efforts. The next day, she might be called to another birth, expected to perform with the same skill and determination. Payment for midwives varied. Wealthy families paid well, especially if the outcome was successful. Poor families paid what they could, sometimes in goods rather than money. A midwife's income depended on her reputation, the community's wealth, and the outcomes of her cases. Failed births damaged reputations, even when failure was inevitable. Some communities provided midwives with stipends or guaranteed payments, recognizing their essential role. Others left midwives to negotiate individual fees. The economic precarity meant midwives had to balance compassionate care with financial survival. Midwives also faced legal scrutiny. If a baby died during birth, the midwife might be questioned about her actions. Did she perform emergency baptism? Did she use excessive force? Was she negligent? These investigations were stressful and could result in fines, bans from practicing, or worse. Despite these challenges, medieval midwives continued their work. They delivered thousands of babies, managed countless complications, and saved lives that would otherwise have been lost. Their knowledge, gained through experience and passed through apprenticeship, represented the cutting edge of obstetric care in a world without modern medicine. How did medieval midwives deliver breech babies without killing mothers? They used their hands to turn babies inside the womb, enduring the mother's screams and the risk of causing the death they fought to prevent. They pulled babies out feet first, racing against suffocation and hoping the head wouldn't stick. They reached inside with hooks when nothing else worked, choosing to save the mother even if it meant destroying the child. They baptized dying infants through whatever opening they could reach, securing souls when bodies were beyond rescue. They worked through blood, pain, and death, armed only with experience, courage, and the knowledge that doing nothing was worse than trying and failing. Some mothers died anyway, some babies never drew breath, but others lived because a midwife refused to give up. If you enjoy the hidden sides of medieval life, hit subscribe and give this video a like.